This is a case of a chronic tonsillitis in a 65-year-old female, and we are performing bilateral tonsillectomy with the help of a monopolar cautery. I am holding the right tonsil with the help of a toothed forceps. I am pulling the tonsil medially. I am incising the mucosa at the level of anterior pillar with the help of cautery. I am trying to find out the correct plane of dissection. As the tonsil are little bit of endophytic, I am having difficulty in finding out the plane. If you are having difficulty in finding the plane, try to extend your incision little bit more lateral to the anterior pillar. Here I am extending my incision towards the lower border so that I can find out the plane in the lower part of the tonsil, and I will follow that plane up towards the upper pole. You have to give a good traction and counter traction so that the difference in the tissue become more apparent. As this is a chronic tonsillitis, we can see the pus coming out of the tonsil, and when the pus comes out of the tonsil, it indicates that we are going into the tonsillar tissue. We don't have to go in the tissue, we have to stay lateral to the tonsillar tissue and medial to the tonsillar bed. You have to give a good traction and counter traction so that the tissue differentiation becomes good. As you can see, I am able to find out the plane in the lateral part. We can use the monopolar cautery to push the bed little laterally. We have to find out the correct plane at the start of dissection so that our dissection does not get compromised in the further part of the surgery. As you can see, there is very minimal bleeding from the tonsil. Even though we are using the monopolar cautery and not the coblation, we can still do a relatively bloodless surgery with the help of a monopolar cautery. Now I have changed my instrument from toothed forceps to an Ellis forceps so that I can give a good counter traction and traction. I am able to see my plane in the lower part of the tonsil. Therefore, I extended my incision in the lower part, and now I am following up the plane towards the upper pole of the tonsil. Make sure your tissue is little wet and not absolutely dry, because a little bit of the wet tissue helps the cautery to work more properly. So I'm able to see a cotyledon, which is the last cotyledon of the tonsil, and now I'm getting a picture of the fibrous tissue of the tonsillar bed. We have to divide at the level of junction of the tonsillar tissue and the connective tissue. We don't have to incise the muscle, which will lead to the exposure of the muscle and later on myositis, which is a cause of pain in the post-operative period. I am making the tissue more wet so that the monopolar cautery also works properly and I can get a better differentiation of the colors. A little bit of the oozing, which is the venous oozing, can be stopped using the monopolar cautery itself, and a large arterial bleed can be stopped with the help of a bipolar cautery. I will give a good traction and I will use the cautery at the junction of the connective tissue and the tonsil. As you can see, the tonsillar tissue is coming out like a book. We don't have to create a tunnel while removing the tonsil, as it will restrict our view. So we have to do equal dissection from all the sides, and the tonsil will open like a book on its own. We have to be little cautious in not damaging the muscle, as more damaging of the muscle will lead to more post-operative pain. We just have to divide at the junction of the tissue and the bed, and you can see the bed with a good amount of fascia all around, and there is very minimal exposure of the muscle. As I have performed an extracapsular tonsillectomy, a little bit of exposure of the muscle is inadvertent. Now I will use a bipolar cautery to stop a little bit of the oozing from the bed. As compared to the conventional tonsillectomy cold steel method, there is a good amount of bleeding from the tonsil, but here you can see a very minimal bleeding, and the fascia is also preserved in the maximum area of the tonsillar bed. After cleaning the tonsillar bed with a gauze, you can see there is absolutely no bleeding from the bed, and the fascia is also preserved. We can say this is an relatively bloodless and a painless surgery. Thank you for